I will be discussing about how to differentiate pleural effusion from lung consolidation, consolidation from atelectasis and effusion from atelectasis based on physical examination and the chest X-ray. First, let's see about how to differentiate pleural effusion from lung consolidation. Pleural effusion is a collection of fluid in the space between the chest wall and the lungs, whereas consolidation is when the normal air-filled space of the lung are filled with the product of a disease. Some causes of pleural effusion, such as pneumonia and the lung CA, are they both cause lung consolidation. Dullness detected on percussion may represent either lung consolidation or pleural effusion. Both pleural effusion and the lung consolidation appear as white areas on X-ray against the darker air-filled lungs. So, due to those reasons, it is even a bit difficult to differentiate one from another. But let's see how to differentiate effusion from consolidation based on physical examination and the chest X-ray. On physical examination, consolidation generates bronchial breath sound on auscultation, while an effusion is associated with a relative absence of sound or decreased air entry. Consolidation causes BBS or bronchial breath sound, while effusion causes decreased or absent air entry. Fremitus will be increased over consolidation and it is decreased over an effusion. Tactile fremitus is increased over consolidation and it is decreased over effusion. On imaging, especially X-ray, both conditions appear as white area against the dark air-filled lung on an X-ray. They are differentiated by how the fluid moves when the patient changes position. Fluid builds up between the chest wall and the lung is pleural effusion. So pleural effusion will move when the patient changes position due to gravity. Whereas fluid or other material builds up inside the lung is consolidation. In this case, or in the consolidation, there will be no movement of the position of the fluid. They won't move when the patient changes position because consolidation is already there, it is in the lung. Whereas effusion is fluid between chest wall and the lung, they will move when the patient changes position. Even though both are white on chest X-ray, the texture of whiteness differs. Consolidation usually causes more heterogeneous shadowing, typically with the presence of an air bronchogram. Shape of the upper border of the shadowing. In the case of fluid, there will have a meniscus, so the upper border of effusion will be concave. As I have said, both pleural effusion and the lung consolidation appear as white area on X-ray against the darker air-filled lungs. However, chest radiograph can miss more than 10% of significant effusion, especially in case of lower lobe consolidation. So in this case, chest CT and ultrasound are more sensitive in detecting small pleural effusion. The second is consolidation and the atelectasis. Consolidation occurs when air in the lung is replaced with fluid, blood, pus, or other substance, as I have said, whereas atelectasis is a collapse of portion of the lung, or it is just a lung volume loss. In the case of consolidation, there is no volume loss. To differentiate consolidation from atelectasis, on physical examination, decreased or absent breath sound can indicate atelectasis, whereas bronchial breath sound indicate consolidation. Decreased vibration or vocal fremitus while speaking can indicate atelectasis, and increased vocal fremitus on the affected side indicates consolidation. Let's see how to differentiate consolidation from atelectasis on chest X-ray. The first one is by looking at volume. Atelectasis is the collapse of a lung which results in volume loss. In contrast, consolidation preserves the volume of the affected lung because alveolar air is replaced by other substance, so there is no volume loss. After an IV contrast medium, atelectatic lung enhances more than skeletal muscle. In atelectasis, the mediastinum, heart, and the trachea shift towards the affected area, and the ipsilateral hemidiaphragm may also be elevated, but in consolidation it's not. In atelectasis, rib spaces on the affected side may be closer together, and the collapsed lung segment and the lobes in atelectasis follow well-recognized anatomical pathway, whereas it's not in the case of consolidation. The third one is pleural effusion and atelectasis. A pleural effusion causes dullness to percussion, while atelectasis causes heterogeneous increased attenuation. Even though there is dullness, it is more prominent in the case of effusion. A pleural effusion causes decreased or absent breath sound, whereas atelectasis causes heterogeneous increased attenuation. A pleural effusion causes decreased or absent tactile fremitas, while atelectasis causes heterogeneous increased attenuation or increased tactile fremitas. On chest X-ray, in atelectasis, the mediastinum shifts towards the side of the collapsed lung, whereas in the case of pleural effusion, the mediastinum shifts opposite on the pose side. In pleural effusion, the hemithorax is larger, while in atelectasis, the hemithorax is smaller. Blunting of the costophrenic angles, also known as meniscus sign, is a sign of large pleural effusion. So in atelectasis, mediastinum shifts towards the side of collapsed lung, whereas in effusion, mediastinum shifts to the opposite side.